Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elsegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Alena Guggenheim, who is a naturopathic physician practicing in Portland, Oregon. She graduated from the National University of Natural Medicine in 2007 and completed a residency in 2009. Over the last decade, she has built extensive integrative programs for patients with autoimmune connective tissue diseases and loves working with the beautiful complexity of the immune system. Today my guest is Alena Guggenheim, who's from Portland in Oregon. Thank you for joining us today.
Thank you so much for having me.
And of course, I didn't say when I should have done that, you're a naturopathic doctor. Would you like to tell us your story? When did you first decide you wanted to get into medicine?
Well, I think I first decided that I didn't want to get into medicine before I actually found it. And that came from, I'm a fourth generation Dr. Guggenheim, and had a mother that went to medical school as a single mom when I was 4. So I really saw firsthand the rigors and the hardship of medical training, and really spent most of my childhood in the call rooms of hospitals while she was going through internship and residency, and really spent a lot of time with patients in the hospital. And I think through that process, I saw the challenges of making health decisions and kind of grappling with oftentimes picking treatments where the treatment was often more harsh than the disease itself, and really kind of knew that I wanted to do anything except for medicine. So when I went to college, I focused on evolutionary biology, and was kind of getting ready to head to a PhD program in evolutionary biology when I met a naturopathic doctor, and I was very interested in how humans have evolved next to microbes, and that was kind of an area of intense interest of mine, of how the microbes around us have influenced our genetic expression and human evolution through the lens of looking how we've been shaped by microbes. So I kind of came to that conversation at a party, and I didn't know what naturopathic medicine was. I knew I didn't want to do medicine. And after kind of having a really lively conversation about what really shapes human health, he kind of invited me to spend some time with him in the clinic and see if naturopathic medicine resonated with me, and it obviously did. Mm-hmm. I canceled my plans to start the PhD program, and instead enrolled in naturopathic medical school here in Portland, Oregon, and I finished that degree a little over 10 years ago, and did a couple years of residency. But I think the real heart into your question is, how did low-dose naltrexone get to me in my practice? And to that, I kind of actually have to go back to the beginning of my story of being very much shaped by my single mom physician mother, who is a very gifted and wonderful rheumatologist. So during school and after school, I would spend all of my time in her rheumatology practice. And, I probably saw 10 or 15 times more patients with her in the clinic than I did in seeing patients in the clinic as a student. So my exposure to that rheumatologic population, patients with lupus and rheumatoid arthritis and polymyositis, and was huge from my time in school with her. And I kind of knew that was going to be a population that I wanted to work with for many reasons, but most of my reasoning is actually coming more from my heart. My heart really just goes out to people suffering from these diseases, because they're so deeply impactful, and they're often kind of silent. It's not like when you go through cancer treatment and you lose all your hair and you become gray. Like, people can see it and they know how sick you are. And oftentimes people with rheumatologic disease, there's still so much suffering, and they often just sort of appear healthy and normal, but their existence is often so limited by the physical disabilities of those diseases. But it also very curiously became an incredible intellectual outlet for me as well, where, going back to what I thought I wanted to do with my life, which was study human evolution, how these diseases have evolved, and intellectually studying how our immune system goes wrong from a mechanistic perspective, and what we can do to go upriver to treat more the underlying causes of why the immune system basically turns mutinous and rogue and decides to attack ourselves instead of maintaining peace with our own tissues. That process is very intellectually interesting to me, and it's really such a wonderful population to work with, where I get to combine my heart and my mind in working with patients with rheumatologic disease. So that is now kind of flash forward 10 years. I don't do primary care. I really just see rheumatology patients and patients with other connective tissue disorders. So particularly the hypermobility joint disorders and Ehlers-Danlos syndrome, and patients with fibromyalgia. So that's kind of become my practice now, 10 years into it, and I speak about this. I publish on this. These are my people. I just want people's joints to feel good so that they can feel good in their bodies and be able to be fully present in their lives. And when your body hurts, that really keeps you from being able to be in your life and be present and stay conscious and be in present day loving relationships with the people in our lives. And our bodies can really get in the way with that. So I think I stumbled on Low Dose Naltrexone when I was still in medical school, so more than 10 years ago, and pretty much started immediately using it anytime I was working with a patient with autoimmune disease, and not just autoimmune diseases, but also Hashimoto's and autoimmune thyroid stuff, and autoimmune disorders of the gut, like inflammatory bowel disease. But now I have actually found many more uses for it in patients that I wouldn't normally 10 years ago have thought to use it in. And that's been, it's been really lovely to feel like I have a very safe tool that has very little in the cost column. So, anytime you're thinking about starting a new intervention with a patient, because sometimes I'm using low dose naltrexone for things I've never heard anybody speak about. I've not read any primary literature to support. So I have to have a very open conversation with my patients. Like, I have absolutely no idea if this medication is going to help you. But what I can say is that it's not going to harm you. It's not going to harm your pocketbook. It's not going to harm you. We don't have to worry we're going to, cause some kind of organ failure. So this is worth a college try because the potential benefit from it is great. Mm-hmm. I have a kind of a recent example of a time that I really had no idea if this was something that was going to help somebody, and it really has made a substantial difference in this patient's life in a context that I would have never thought to use it. I don't know if this is a good time to talk about some patient stories, but
please do.
Yeah, okay. So I've been working with a patient who has Marfan, which is a genetic collagen disorder that causes problems in the musculoskeletal system, but one of the more serious problems that it can cause is aortic dilations and dissections. So this particular patient, he has a very large aortic dissection, and he's actually had multiple surgical repairs and has almost died many times. He's young. He's in his late 20s. But he lives kind of every day with the knowledge that he might die with this very large dissection in his abdominal aorta. But the thing that really gets in the way with his life is pretty severe low back pain. And his low back pain keeps him from being able to get all the way around in the grocery store, walk more than 2 blocks. He is very physically limited, not by the dissecting aneurysm, but by his pain. And we did imaging on him, and he was found to have something called a Tarlof Cyst, which is kind of a dilated sac in the bottom of the spinal cord. And this Tarlof Cyst can happen whenever somebody has certain kinds of collagen defects that basically is, their collagen is sort of like really cheap quality balloons. Those balloons where you kind of blow them up and they just pop because the plastic is so poor. So he has all these large dilated cysts in his spine, and they are actually large enough that if he were more medically stable, is something that could be treated surgically. They can kind of tie him up in they can kind of stick him in some sacks and try and stick him back in. But he's not medically stable enough for any kind of spine surgery. And, I was sitting with him, we were kind of talking about his disabilities. And I kind of thought like, hey, this is not a time I would have normally thought to use low dose naltrexone. I'd read one of the studies on just sort of using it for low back pain. And we ended up, he's quite heavy. He's around 290 pounds. So we ended up going a little bit in a higher dose than I normally do. And he's now stable at about 5.5 milligrams. And this is it's improved just his pain at rest. But the thing that's been really noteworthy is that he's in cardiac rehab. So he goes to cardiac rehab multiple times a week. His ability to maintain his baseline ability to get on, he has a very special kind of recumbent elliptical that he does at cardiac rehab. He's actually starting to gain some physical strength in a way that's not dangerous for his aneurysm. That he's been unable to sort of maintain a baseline strength after, I don't even know how much cardiac rehab, but he's doing really well. And it was definitely let's just try this one thing. I'm not going to put any other treatment plan in place because I really want to know if the low dose naltrexone is helping or not. And, it was a pretty clear yes. I like to joke that sometimes my patients are kind of dirty Petri dishes because we start many interventions at the same time, including low dose naltrexone. And then it can be kind of challenging to know how much is this patient being helped from the low dose naltrexone? How much are they being helped from all the other interventions that we're doing to try and address the root causes of disease? And not to just kind of go off on a tangent, but if it's okay with you.
Yes.
Sometimes I have patients ask me, because I give them a little bit of an introduction whenever I start working with somebody with an autoimmune disease. And I'm very lucky. Half of my, one whole wall in my clinic space is a whiteboard, so I get to draw big pictures and get kind of artistic with it. But I tend to kind of talk about like the root drivers of disease. Like what are the reasons that people's immune system really flips that switch and goes autoimmune? And I kind of have a little bit of a different map in my head for each of the autoimmune diseases. So, my map for ankylosing spondylitis is a little different than my map for lupus or my map for rheumatoid arthritis. But the basics of it are, genetics. So we've got genes playing a role. We've got epigenetics, sort of post-inheritance changes in our genes. We have environmental exposures. We've got nutritional deficiencies and nutritional excess. So, actually one of the biggest predictors of who's going to get rheumatoid arthritis is the ratio of omega-6 to omega-3 fatty acids in the blood. So having too many omega-6s, not enough omega-3s. We've got hormones, so thyroid hormones, adrenal hormones, sex hormones, and then how all those hormones are metabolized can greatly influence how the immune system behaves. And I think of low dose naltrexone as fitting into the category of psychoneuroimmunological intervention. So this is how our psychological and our neurological chemicals, like how the chemicals of our nervous system land like rain on our immune system and change the way it's going to behave. Because I try not to just throw palliative or suppressive medications at people. So I'll often get patients asking me, like, isn't low dose naltrexone just a Band-Aid? Like, is this just a Band-Aid medication, like the same way that taking methotrexate or Enbrel or, one of these medications is sort of a Band-Aid for this? And I really think fundamentally low dose naltrexone is not a Band-Aid because it is changing the fundamental neurochemicals of our immune system. And this is part of the reason, this is part of the terrain or the milieu that allows autoimmune disease to bloom. So if they look at the T lymphocytes of a patient with RA, the level of beta endorphins is about 10 times lower on the surface of that T cell in in receptors compared to a healthy, normal functioning T cell. So rheumatoid arthritis is essentially partially a disease of opiate depletion. This is part of why that disease occurs. Now, I think kind of the bigger and maybe more interesting question is, what led somebody to be in that state? Why are they having a beta endorphin deficiency on receptors on the outside of their cells? And that turns out, of course, to be a much more complicated question. But what I really love about low-dose naltrexone is that it's not suppressive. You know, I'm not sitting there having a conversation telling somebody that when they're taking this medication, if they get a fever, you know, they need to go to the emergency room and potentially be admitted. You know, they still have a fully functional immune system. In fact, probably a more functional immune system for infection risk and compared to other DMARDs, which are the disease-modifying anti-rheumatic drugs, which universally cause an increased risk of infection. Another question that your listeners might be thinking just in this conversation, because I do use DMARDs, I do prescribe them. I don't think that they're evil or that they, you know, have no place in treating these diseases, because they really do. When a fire is burning so hot, it's like I think about it sort of like a forest fire. Like sometimes you really do need the airplanes to come in and dump the fire retardant. And you still have to be doing all the work behind the scenes as to why the fire started in the first place, with the end goal of getting patients off of these medications faster. So I don't hate DMARDs. I prescribe them. I use them very judiciously when they're really needed. And, you know, one of the questions I'll have patients ask is, hey, you're starting me on, I'm just going to use methotrexate and Enbrel as an example. Should we just stop this low-dose naltrexone thing because we're going on this heavy-duty immune suppressive regimen? And 10 years ago, when I first started practicing, I totally stopped the low-dose naltrexone, and I would just support them in other ways when they were taking these very heavy-duty medications. Now, I absolutely do not. I always try to keep patients on low-dose naltrexone when they're taking other immune suppressives, because of the other immune modulatory impacts that LDN has. So we know that one of the risks of the whole class of medications that Enbrel belongs to, they're called tumor necrosis factor inhibitors, is an increased risk of infections and an increased risk of cancer. Well, what are two things that low-dose naltrexone does so well? It improves our immune system's ability to identify and get rid of aberrant, naughty-looking cancer cells, and it improves our ability with certain types of infections. And this is, again, I'll have the conversation with my patient, like, hey, nobody has taken 5,000 patients. 2,500 of them just get Enbrel and methotrexate, and the other 2,500 get methotrexate and Enbrel and low-dose naltrexone, and then followed them for 5 years to see, you know, is the cancer risk, is the infection risk really lower? So I'm really super clear with patients. Nobody's going to dump the multi-millions of dollars that you would need to design a study like that. But going back to the fundamental conversation of potential harms, the potential harm of continuing the low-dose naltrexone is very low. So I try very hard just to keep my patients on it, even when they're doing the more heavy-duty medication.
Mm-hmm. I'm going to have to stop you there. We've just about run out of time, but just one sentence.
Sorry, I feel like I didn't let you get any questions in.
That's absolutely fine. But before we finish, can you just tell me LDN for pain for, say, rheumatoid arthritis? What are the outcomes? What success rate do you get? What percentage of people find that LDN helps with their pain?
That's a great question. I'm going to answer it with a little bit of a roundabout way of getting there, which is in rheumatoid arthritis in particular, pain and joint disease and activity, sort of the rate of joint erosions and how active the disease are not necessarily the same. So patients can have a lot of pain, but the actual progression of the disease and how active the disease is can be low, and vice versa. So patients can have relatively very little pain, but be getting progressive erosions and deformities to their joints. So my hope is when I'm using low-dose naltrexone that I'm not just decreasing pain, but that I'm decreasing the actual immune destruction of the joint. And sometimes those don't go hand in hand. So I am going to have a little bit of a hard time answering that because I'm always looking at both. I'm looking at sort of standardized disease activity markers, like the DAS28 or the RAPID-3, and I'm trying to really assess how active the disease is. Mm-hmm. So using that as sort of more my base, I'm going to say that I kind of categorize things like patients who receive substantial benefit, I'm going to say is probably about 20%.
Okay.
Patients that receive moderate benefit, I'm going to say is probably about 60%. And then I maybe have 10 to 20% where I don't think that low-dose naltrexone makes any difference at all. Mm-hmm. But it's also, again, a little challenging to answer that because I'm often doing more than one intervention at a time. And going back to like the nutritional things and the environmental exposures and the hormones that are at play with these diseases. So I'm often kind of have my hands cooking in multiple pots. So that's a little tough to be very precise.
Okay, well, we've run out of time. Could you tell our listeners how they can contact you?
Yes, so the best way to contact me is probably through my email, which is my first name, Alena, ALENA, .Guggenheim, GUGGENHEIM @gmail.com.
And thank you very much for having joined us today.
Yes, thanks so much for having me.
This show is sponsored by Alena Guggenheim, who is a naturopathic physician practicing in Portland, Oregon. She graduated from the National University of Natural Medicine in 2007 and completed a residency in 2009. Over the last decade, she has built extensive integrative programs for patients with autoimmune connective tissue diseases and loves working with the beautiful complexity of the immune system. Any questions or comments you may have, please email me, Linda, Linda, @ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.